Both miss you and hope you are doing well. We look forward to seeing you again the next time your computer crashes and you come down for something to eat. So this is actually a good day for a parent of adolescents, where your kid is hiding away from you, but you know where they are, and you have some predictable sense of when they'll reemerge. But having that kind of zone of freedom in which adolescent stays somewhat connected, or keeping channels or bridges open to their family, is really important. Because adolescents are at risk. About 75% of all mental disorders have an onset before the age of 25, not just BPD. So we have to look for a variety of symptoms or early signs or precursors to a number of different disorders during this period of time, alongside with the normal turmoil of adolescence, which is a very hard thing to differentiate. There are all these social and emotional developmental tasks that I think us as adults, we never want to go back to being an adolescence, because managing friendships, getting into new relationships with love interests, those are all fraught with anxiety and intensity and drama for anyone. And then there are all these structural and functional changes in the brain that go on. There's a pruning process where there's some connections that get groomed out to increase efficiency in the brain, and there is increased myelinization. So there are all sorts of biological changes that the young person in adolescence experiences and has to manage on top of all these other new experiences. This also puts them at risk. And when young people show symptoms early on, this can actually be a kind of early sign of worse things to come if they're not addressed early. So this is, again, the theme of early intervention. The earlier these symptoms can be noticed, diagnosed, and attended to, the more they can be addressed and resolved. So once symptoms start to evolve, mood disorders and BPD, other psychiatric problems, will have their peak in adolescence and young adulthood. And the mean age of onset in some studies show that it peaks around 18, which is a critical period when kids, at least in some cultures, will start leaving home, definitely go on to university or other bigger responsibilities, and this increases many forms of stress. And for those who start to show symptoms early in adolescence, there are some studies that show that this is a risk for poor outcomes down the line, including increased risk for substance use, mood disorders, interpersonal problems in general, which feed back into risk for psychiatric problems, high use of psychiatric services, and other medical problems. So one of our colleagues, Andrew Chaman, has done a lot of work in trying to describe the differences between risk factors, precursors, early symptoms, and full-fledged symptoms of psychiatric disorders in young people. The problem is... Closer. Okay. Better. Okay. Thank you for being so vocal. Now I feel better. You care. You want to hear what I have to say. Okay. So I was just talking about the work of Andrew Chaman. He's a child psychiatrist in Australia who's been very active in the idea that early intervention is really critical, and a kind of brief, focused approach to helping young people can resolve symptoms that are vulnerabilities for all sorts of psychiatric illnesses early. And what he thinks is really important that we focus on is that there are risk factors, precursors, or early signs, and symptoms of disorders that we sometimes confuse altogether when we think about psychiatric problems. So just to keep this in mind, it's important to know that there are risk factors for borderline personality disorders that is shared with other disorders, okay? So these risk factors include genetics. The heritability of BPD is now estimated to be between 40 and 60%. That means the risk for developing BPD is about half contributed to by genetics. So there is now evidence that there's a biological basis to BPD. There are also some early signs, neurologic abnormalities. Some people think ADHD is something that shows early on in a child's life. That may be a precursor or a risk factor. It's really hard to differentiate between the two. And then there is early childhood adversity. The work of many researchers, including Mary Zannarini, indicates that early adversity by parental failures may include inadvertent invalidation or neglect, or even in some cases abuse. This increases the stressful sources of risk for a child who has vulnerabilities that may combine with those vulnerabilities to produce many psychiatric illnesses. People who eventually go on to develop BPD often show early relational difficulties. John Gunderson indicates that early signs include having exclusive relationships throughout childhood, where a child may not have many friends but only depend on one friend at a time, or may have difficulties getting along with others in their peer group. And there's oftentimes a family history of psychopathology, not just borderline personality disorder, but also depression, substance use, and other behavioral disorders. Now, then there are precursors or predictors that are just one step closer. Risk factors only increase risk for developing disorder. Then there are these more proximal or closer phenomenon that show up near the onset of the disorder, including other disorders such as ADHD, oppositional defiant disorder, where there's a disregard for rules or consequences, behavioral discontrol, conduct disorder, substance use disorder, especially alcohol early on. Suicide attempts and self-harm together are more predictive of borderline personality disorder than self-harm alone. You may have heard that in yesterday's talk. Depression, temperament, which I'll talk about. Some children are born with a more reactive temperament, and they may be showing more signs of reactivity to stress in their environment earlier on. And then, of course, there are some BPD features that start showing up earlier than others. And that's when you start having to pay attention and intervening with some basic strategies of care. Now, how do we put all this together? This is a very busy slide. This is taken from a paper by Carla Sharp and Peter Fonagy from 2015. And the only thing I really want you to focus on is that there are all these biological factors, individual factors like the genetics, genetic polymorphisms, which are just specific gene endowments. And then there are endophenotypes, how these things start to show up in a person on a biological level in an MRI, but then on a behavioral level or cognitive level with problems of social perspective coordination, hypermentalizing, which we'll talk about, impulsivity, and emotion dysregulation. So this is where these symptoms start showing up. But these are individual features that are there sometimes from birth and start to develop through childhood and then start to express themselves at this critical developmental time in adolescence. And then this is the final outcome, the BPD. So you can't just wait until this fully expresses itself to start to do something about it. Now, the important thing is, if you look at the top and bottom, there are contextual risk or vulnerability factors and also protective factors. And if you notice, all the risk factors are interpersonal. They include sexual and physical abuse, maladaptive parenting, and parenting is prone to become maladaptive in the face of stress. I want you to remember that. There's peer victimization like bullying and attachment disorganization, where the child responds to the unreliability of their environment by becoming controlling in different ways. Sometimes that control is achieved through being aggressive. Sometimes that control is achieved through being people-pleasing. Now, at the bottom, there are protective factors that I want you to keep in mind throughout the rest of this talk that include secure attachment. This is what treatments and families should strive for stabilizing and securing the attachment system, because that can help protect an individual from all of this going downstream to full-scale BPD and relatedness. And so any treatment intervention that includes promoting attachment and relatedness and stabilizing relationships can help a young person who has risk for BPD. That's the punchline, if you remember nothing else about that. Okay, can you all hear me still in the back? Yes, okay. Another early feature of individuals who go on to develop BPD is that they have complex comorbidity. So what you'll see is that people who develop BPD in their youth, about 60 to 70% of them will have a mood disorder, anxiety disorder, and what we call an externalizing disorder, a behavioral problem. So when you see that constellation of multiple psychiatric problems together, the likelihood that that may be BPD is there. So you can pay attention to that. This is a graphic that shows a new way, a dimensional way of thinking about risk for psychiatric disorders, because we all know that those patients that become more difficult in our practice have multiple disorders. And if you try to treat all those separately, it can become a very unmanageable mess, right? But if you can think of things as groups of disorders, you can sometimes target their source in a more broad way. Meaning that if you think about internalizing disorders together and you help people manage their distress and fear, it can treat all those disorders that arise from problems with that. Similarly, there are externalizing problems, which are more behavioral disorders, and they are treated in different ways, okay, with much more contingency management. So the thing about BPD that's unique is that BPD combines features of internalizing disorders and externalizing disorders, anxiety and mood problems, as well as behavioral problems. So again, when you see that combination of features in a young person that's a patient, there's also a question in your mind that should come up, is this BPD? And the last reason I want to mention that this is important to detect early on is that there is now evidence that was published by Carla Sharp and her colleagues that BPD is a generic paradigm, a general paradigm or a model of personality disorder. So what she did was she looked at the way that the different symptoms of different personality disorders cluster in what we call a factor analysis. And what she found was that while the different symptoms of obsessive compulsive personality or avoidant personality or schizotypal personality disorders loaded onto those disorders, the symptoms of BPD loaded onto general factor of psychopathology. And basically what that means is that people who have features of BPD are more likely to have a lot of different problems based on the dysfunction and the vulnerability of their personality functioning. Okay, this is why they're more likely to have complex comorbidity, and this feeds into the self-management and interpersonal problems the person with BPD will have. Now the good news is that there are a lot of evidence-based treatments that work for this disorder. So people who have BPD don't have to manage it alone. The first of these I won't get into because many people here are expert in DBT and your program teaches about this well. But what I will focus on is explaining the models of BPD in every treatment approach so that you can think about this with patients or families and use it as a concept that you use to help them understand what's going on with their loved one. So in DBT, there's something called the biosocial theory of how BPD develops. So it starts on the left with a person who has emotional sensitivity that meets the invalidating, stressful environment, right? We were talking about this. I still need to know how Puerto Ricans are more invalidating than others because if you've been to the Northeast, pretty invalidating. So we should talk about that. But this will happen to everybody. Everybody enters into an invalidating environment. People who have emotional sensitivity will react with more difficulty and more strongly. And what happens in both directions is that that emotionally sensitive person gets triggered into symptomatology because of the transaction between this invalidating environment and their sensitivities. When that environment fails to meet that person's special needs for a variety of reasons, there's a lot of bidirectional blame and denial. The person with BPD will see the failings of their environment and they will avoid thinking about their own vulnerabilities in the process, and the environment will do the same. They'll blame the student or the patient or the person with the vulnerabilities, and that only escalates problems so that it becomes a more difficult environment for that person. So then, instead of talking and relating, the interchange is based on solutions rather than understanding. Okay, and it was a really nice illustration to hear how this family came to talking more, describing more the problems, instead of trying to control each other's behavior. Now, what we know about this for adolescents, there's not a lot of research on treatment for adolescents, but DBT has the most trials, like for adults as well. And it is superior in reducing self-harm and suicide attempts. This is really important when a family is coping with, or a young patient is coping with suicidality and self-harm. This is probably the go-to treatment when it's available. Now I'm going to spend a little bit more time talking about the other models because they're probably not as familiar to you. Not because they're more important. Okay. So in mentalization-based treatment, this is a treatment that comes from England and has been developed from attachment research and research in developmental psychopathology. So what they have learned about attachment is that we all develop the capacity to reflect about ourselves and others and understand relationships and actions within relationships based on mental states. That is, thoughts, feelings, desires, intentions, all of those things underlie the interactions that we all have. And when you can think about relationships in that way, it helps people to understand each other, be flexible, be less reactive. And in reverse, when people don't mentalize, they can become more reactive and escalate relationships to be more intense and fraught and conflicted. So when a person fails to be reflective, what happens is that they're plagued by all these other non-mentalizing modes, concrete ways of thinking that you know exactly what other people are thinking, being able to read people's minds only on the basis of behavior, so thinking that people have to prove to you how much they care, or you have to prove to them how much you're hurting. And lastly, hypermentalization, where you have these elaborate stories about why people do the things they do. These are all characteristics of dysregulated mentalization or dysregulated reflective processes. And this is the basis of all the symptoms of BPD in this model. So the solution then is to help people mentalize more flexibly, more stably, especially through stress. And the important thing about this model to remember is that it really proposes that people with BPD can do this well when they're not overly stressed. So patients can think about what's going on with other people. They can understand themselves. But when they hit a point of arousal or stress, or an attachment is too activated, their brain will flip from using the front of their brain, the thinking, evaluating part of their brain, to the deeper part of their brain. There's subcortical areas that are more emotion or memory driven. When that happens, there's a difficulty for the patient in order to evaluate their thoughts, to have what we call metacognition, to understand that thoughts are thoughts and that they could be wrong about their beliefs. So this is where schemas, core beliefs, and memories and enactments come from. So in this model, people with BPD are plagued with all different sorts of problems in mentalizing, like psychic equivalence, pretend mode, teleologic mode, and I don't want you to get too hung up on the terminology because that's not the part that's important. But the thing I want you to pay attention to is that for adolescents particularly, with BPD, they are prone to this problem of hypermentalization, where there's a tendency to construct elaborate, detailed psychological explanations for relationships that exceed expectable inferences in the absence of data. So teenagers who have BPD get very certain that they know exactly why someone's done something, and that is not amenable to reconsideration when people try to talk to them, be more logical, help rationalize the situation more. They may be really stuck. And the important thing about this is that this model accounts for why people with BPD aren't amenable to some of the feedback in psychotherapy. Some therapists try very hard to deliver interpretations or correct core beliefs for people with BPD, but when they're not mentalizing, they can't take this information in. So the job of the therapist in MBT is to get the patient to start mentalizing again. And how they go about doing that is by something called contingent and marked mirroring. It's really basically a different version of validation. So this comes from a developmental model or attachment model where they think that when a child starts out in distress, this baby right over here, whether it's a child or an adolescent or an adult, when we're in distress, we give cues. They're called attachment bits that really communicate to others that you need help. So depending on the effectiveness of that attachment bit, the caretaker will respond in a certain way that reasonably reflects their understanding of what's going on. So when a baby's crying, what face do you make? That one's perfect. It's a face that communicates there's something that's going wrong for you. You don't start crying yourself, so you're not literally mirroring that child, but you're giving back a metabolized or a marked version. This is what I think you're thinking, okay, to the child. And that's a representation of what you think is going on in that state of distress. And when you are able to do this, it allows the child or the young person or the patient to think about what's going on rather than just be overwhelmed with it, okay? So this is a process that goes on in early childhood throughout a person's life, and when it's done reasonably consistently, people develop a psychological understanding of themselves. But what happens for the young person who has a more reactive temperament or sends attachment bits that are not as effective, they're not as clear, they're not as open, they're not as understanding of their own problems, that's where this can go wrong, okay? And disrupt the ability to understand oneself in a way that promotes attachment. So what they do in mentalization is basically just assess when mentalization goes offline, meaning that you can tell a person isn't reflective. They're too stuck in a thought, or they're too detached, or they're too hypermentalizing, and you just want to help them stop, slow down. You want to mirror back what you understand is going on with them, provide some validation, and then sort out where they are with things. Okay? And in this process, you want to be careful to not overly activate their attachment system because they're likely to get hyperstimulated by that. And so you want to stay objective, emotionally contained, available, and curious. And you want to help them balance out the extremity of their thinking. Okay? And it's only after that happens that you can do more complex maneuvers in psychotherapy, whether it's safety planning, chain analysis, interpretation, whatever the technique is, it's made more effective by helping the patient mentalize first. And when this becomes important is especially in patients who show personality disorder symptoms from several different diagnoses. So what this shows is that MBT, when compared to just good clinical management, it's called structured clinical management in this study, when there's only one personality disorder, it does just as well as something that's good care, well-informed. But when there's 4 personality disorders, this is where MBT is more important. So again, a cue into when you will use a more specialized treatment. So there is one trial that's considered MBT in adolescents done out of England, and it was also superior in reducing self-harm and also symptoms of depression, like DBT. And it also showed that it was more effective in reducing attachment avoidance and increasing mentalization. So in this study, the investigators proved that what was happening in the treatment was an increased mentalization, a securing of attachment functioning, and this led to decreases in self-harm and depression. I think I'm going to skip this one in the interest of time. Now, I've talked about some of the specialist approaches to BPD, and they're great when they're accessible. I think they should be used. But the problem is they're not widely accessible, even in a place like Boston where there's a lot of experts. Not everybody who wants treatment can obtain it. So there's this problem of over-specialization. This cartoon says, I'm sending you to a specialist, don't tell them you know me. And there's not a lot of cross-communication between the world of people treating BPD and the world of generous clinicians who are on the front lines. And this becomes a problem in the task of early intervention. That by the time a person evolves severe and recalcitrant enough symptoms to see a BPD specialist, they're already far down the road of developing problems. So what we're advocating for is thinking about more broad, brief, less intensive approaches to BPD. Recently, there was a meta-analysis done by a group that looked at all the randomized controlled trials of psychotherapies for BPD, and what they found was humbling for all of us. They found that there were only small to moderate effect sizes for treatments that were specialized. That means that they work, but their superiority was small to moderate over the other treatments, even just treatment as usual. And there were no significant differences between treatments. So there's lots of different things that work. DBT, of course, has a more robust evidence base and more expansive system of proliferating that treatment. There's more teachers, there's a better system of training, but there is no evidence that DBT is superior based on this meta-analysis. It doesn't take away from the utility of that treatment. But what they did find is that when the other group got as much attention from the study team or the treatment developers, they seemed to do almost just as well as a specialized treatment. Similarly, Marsha Linehan did a dismantling study that looked at the different components of DBT, and she and her group compared skills group training with case management, very good case management where they're constantly evaluating suicidality and self-harm, plus standard DBT, which includes individual therapy, skills group, and the coaching, consultation team, everything, and also just the individual therapy without the skills training. And the good news is all these elements were really effective. And the skills group training with case management and standard DBT were more effective in reducing self-harm, anxiety, and depression. So that's a clue into the possibility that scaled-down treatments can be effective for patients who have BPD, even when specialized treatments may be more ideal. And lastly, I'll talk about placebo responses. In the world of psychopharmacology studies, we know that actually the placebo has significant improvement in patients with BPD. It can decrease affective dysregulation. It has moderate effect sizes for this, cognitive perceptual problems and impulsivity. And it seems that there's something about patients who have BPD that are sensitive to a-specific therapeutic effects. If you give them care and attention, you support them, you try to help them with their problems, that in itself can help them a bit. Not as well as these intensive specialist treatments, but it's worth doing in the absence of that kind of care. This is just a breakdown of the data that we looked at in all these randomized controlled trials that looked more at the treatment as usual outcomes than the treatment of choice. And what we found was that BPD patients improved on most measures even without specialized treatment.